webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. These webinars are presented on the third Thursday of each month. So, next slide.
It's not going.
We'll get to the next slide in a minute. Okay. As we wait to advance the slide, look at, there we are. There's our map. Located throughout the country, there are 12 regional telehealth resource centers and 2 national centers. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. My name is Becky Jones, and I represent the TexLa TRC serving Texas and Louisiana. Next slide. Just a few tips before we get started. Your audio has been muted. Time will be reserved at the end for Q&A, and there's a little Q&A box at the bottom of your screen where you can click and enter those questions. We value your input, and we hope that would love for you to fill out the post-webinar survey. This webinar is being recorded, and recordings will be posted to our YouTube channel, and it will be available through the National TRC website. So today's webinar is presented by the TexLa TRC. And it's my pleasure to, you can advance the slide, to welcome our speakers for today. Both Amanda Freeman and Shawn Parrott are licensed professional counselors working for the Texas Tech University Health Sciences Center Institute for Rural and Community Health. Amanda, wave Amanda.
Hello.
Amanda Freeman has her Master of Education from the University of North Texas. She's been practicing professional counseling since 2008. Amanda has worked in the private practice sector for over 7 years and has worked with a variety of populations, including adolescents. Shawn Parrott has worked previously for 6 years as a licensed professional counselor and a supervisor for a residential treatment facility that provided drug and alcohol rehabilitation. A major professional focus was the treatment of dual diagnosis clients participating in the treatment program. Shawn graduated from Wayland Baptist University in 2009 with a Master's of Arts in Counseling. So I will turn the presentation over to Amanda and Shawn.
Great. Okay, well, before we get started, I want to introduce our core team that not only includes Amanda and I, but we have our project director, Travis Hansen, our project manager, Kelly Munoz, Amanda, myself, and we have a third licensed professional counselor that works with us as well, and his name is Ronald Martin. He's not participating in this webinar with us. We left him back in the office to work on our TWITR, project and everything else that's going on over there. So anyway, that's our team.
Okay, so our objectives for today. Go ahead, Shawn.
Okay, objectives would be access to mental health care in rural West Texas. Purpose of the TWITR program, we'll cover that. We'll also talk about the benefits of telemedicine. We'll talk about exactly what TWITR is. We'll go into detail about exactly what it is, what it means, and what we do as professionals and how we provide resources to kiddos in rural areas that don't have as much access as maybe some of the larger cities provide. That will include the TWITR referral process and, of course, the effectiveness of TWITR, how we track and keep up with the clients that we see and work with.
Okay, and so TWITR stands for Telemedicine, Wellness, Intervention, Triage, and Referral. That's our referral project where we really use telemedicine equipment to give kiddos in rural schools mental health care. But to really, before we get into TWITR and explain it, give me a moment to kind of go over with you what we're looking at in Texas. Texas is a huge place, and if you look at this map here, the Health Science Center, we serve a significant portion of Texas. And if you'll see, all of the yellow areas is our rural areas, and all of the orange is our urban areas. And so out of all of the psychiatrists that we have in Texas, only about 5.3% of them are located in West Texas, and particularly mostly in our Lubbock, Amarillo, Wichita Falls, and El Paso areas. So people have to drive a significant amount of time just to access care with a psychiatrist. So if you're way down in the bottom of Texas in Presidio, you're looking at basically like a 6-hour drive, or a 3-hour drive, sorry, to El Paso for the nearest care for mental health. And 94 of our West Texas counties have no psychiatrist. And again, you see where the majority of them are located at. And out of all the psychologists that we have in Texas, only a little over, maybe almost 6% of them work in West Texas. And I know from being in the private practice sector, even before here, working with psychologists, there's few and far between, and we're very scarce in psychologists around here, and they travel in our rural areas to do evaluations. A lot of them will do evaluations in juvenile justice centers, and we don't have enough of them. And then our counselors, looks like we have a whole bunch of counselors in Texas, 21,000, but only almost about 10% of them are located here in West Texas. And again, that's going to be in more of your urbanized areas. And when we go out to our rural schools, it is so difficult to find counselors for these kiddos in those areas because there isn't any counselors in our rural communities. We have a few here in Lubbock that will travel out, but besides that, people have to travel to the nearest one would be like Lubbock. Okay. All right. And so let me talk a minute about the purpose of TWITR and how it was formed and how it was born. So the idea of TWITR, it began following the year of 2012 when we had a horrible year for mass killings in the United States. So if you'll remember, we had the Aurora, Colorado theater school shooting. We had our Sandy Hook Elementary school shooting where Adam Lanza fatally shot 20 children and 6 staff members. And unfortunately, these aren't our first mass school shootings, and they haven't been the last. And then, in the past, in 1999, we had the Columbine shootings, the Chardon High school shootings, and those are just some of the examples. And so while many thought the availability of firearms was the real culprit in these killings, examination of other mass school violence in other countries again pointed to underlying issues of mental illness. For example, from about the time of 2010 to 2012 in China, there were numerous mass stabbings, hammer attacks, cleaver attacks, which those resulted in at least 25 children, adults killed, and over 115 injured. And the main basis for those events were stress and mental illness. And although these are horrible mass killings, they are the exception rather than the rule. Most of our school-based violence involves student-to-student interactions or student-to-teacher interactions. And because of that, our past governor, Rick Perry, wanted a model program to go into schools and to screen and assess those children who would be a risk to violence themselves or others. And he wanted to locate them, find them, and get them the services that they needed so perhaps we can prevent further violence in our schools and keep schools safe. However, I do want to make clear, you can never predict a shooting in a school. You can never predict something is going to happen. However, we believe by doing this that hopefully, possibly, we are preventing something in the future that could happen. And we know that this is an issue because we've had some shootings here even in Texas. Let's see, I think I have some of that data here. We've had shootings back in 2016, I think 2012 or 13. We had shootings in Austin, in Houston, where there were some children that had been killed. There was, I think it was in Houston, I believe. It wasn't at Shawn, where they had gang members go in and there was a mass shooting. So even though Twitter is in here, we're in this small area of West Texas, we still have a lot of stuff going on around us, which shows that there needs to be some type of intervention.
Most recent that I recall would be Alpine, Texas. Isn't that correct?
That's right. That's right.
And Alpine is a very isolated region where, you know, as we've discussed, the need for more access in the really small rural areas. Alpine is one of those that probably have to drive a long ways to see a counselor, to see a psychologist or a psychiatrist. So that's the most recent one I recall.
Right. You're right. And so the primary purpose of Twitter is to promote school safety by going into the schools, by screening, by assessing and offering referral sources to students who may be struggling with behavioral mental health issues. And then also another part of that we do is we provide training for our teachers, our administrators, our counselors, all staff members in the school. We go in and we train them on basic mental health concerns that would be common to school-age children. And that's my turn. Okay, goals of the Twitter project. So what we're doing is we're interfering with those students who may fall through the cracks. So we're catching them early, so hopefully they don't end up in the juvenile justice system. What we do is we collaborate with our schools, we develop relationships with them, we help ISD staff and faculty members understand mental health symptomology. And the reason we do that is there are specific children that we are wanting to screen and roll out. And so we train them on those signs and symptoms to look for. So when those students are identified, schools have a mechanism to use to get those students help that they need. And we provide at-risk students access to a psychiatric evaluation using telemedicine if needed.
So why telemedicine? We use telemedicine technology largely to bridge the gap between the rural areas and a larger area that has more services. We use telemedicine as the way to provide, like Amanda's mentioned, telepsychiatry. In that telepsychiatry helps to minimize the expert care that is not available near their homes. That leads to inconvenience and cost of traveling to distant cities, especially if they need ongoing visits. And it's refreshing to see as we provide this service to the child and to the families how much relief they get from it. We go out and visit the schools twice for the telepsychiatry and then try and get them plugged into driving into Lubbock. But it's such a huge help to them, and you can tell, you can see on their face how much they appreciate us going into the schools to be able to provide this link.
Okay, so this is a brief idea about our referral process. So I'm going to show you kind of in a picture form how this works, how it happens, and then we're going to go into depth on each one of those. So we get a referral from a school, and the way that works is typically it's through a school counselor because that's who we have most of our communication with. However, anybody can refer a student to Twitter. Sometimes it's the parent that comes to the school and says, hey, my kid needs help. Sometimes a teacher notices things. Sometimes the janitor even may notice something and let the school counselor know. So the school counselor emails us and gives us that referral. And then we, as the licensed professional counselors, we drive out to that school district, which currently we are in 10 school districts, which are located in 9 counties that are within a 50-mile driving radius of Lubbock. And there's only 3 of us, so we had to kind of limit it to that 50-mile radius because obviously it takes almost all day to do this. So we drive out to the school, we perform a pretty lengthy assessment, and I'll go through that in a minute about what we do. Then after we gather all that information on Fridays, we staff with our psychiatry department. And at that time, we present the case, we present the child with all the information that we have, and we staff them or we triage them, where the psychiatry then decides whether or not this student would be a good candidate for psychiatry services. And then we provide recommendations back to the school whether or not a telemedicine appointment is needed. And if it's needed, then we follow up with the appropriate people, the parents, the school, and we set that appointment up. And so we go out and we provide at least 2 psychiatry appointments in the school. And then at that point, if they are still needing psychiatry services, which most of them do, Then we link them up with our Texas Tech Psychiatry Department here in Lubbock. They become a permanent patient of Texas Tech. But one thing important to know that where we're at in the rural communities, this is most of our students come from low SES backgrounds. And so there's limited access to transportation to get to Lubbock, not enough gas to get to Lubbock. So oftentimes our psychiatrists will speak with the primary care physician that's closest to them and can transfer services back to them, and they can collaborate together to let that doctor know what medications that kid is on so that care can continue, but they don't have to drive all the way back into Lubbock, because we know that that's kind of a pitfall. That's kind of the limitations that we're seeing out in our rural communities. And the reason we do too is because that's what our grant allows at this moment.
Now, next we'll go into the specific reasons why we would receive a referral from participating school. So imminent danger to self or others is one of the main referral reasons we see. Anger, violence, anxious behaviors, problems with attention, decline in academic performance. And so we definitely see that often, especially with kiddos that are having, have multiple reasons for referral. Typically, all of their grades are pretty low. They have a hard time focusing on that when they have other psychiatric issues, of course. Definite frequent or intense mood changes, low self-esteem, non-compliance, just definite frequent behavioral issues and reports within the school. Substance abuse, truancy, self-harm, and suicidal ideation. And so those are the main reasons for referral. And I'm sure there's others too. These are just the ones we see, most frequently.
To kind of piggyback on that with what Shawn was saying is, I mentioned before that we go into the schools and we train staff members on what to look for, what to prompt a TWITR referral. And, there's always signs and symptoms that lead up to an event. And if you look back at the past violence in schools, if you look back at our past school shooters and you look back at their patterns, there were signs and symptoms that led up to that. And so we train the teachers on some of those signs and symptoms to look for. These are what's commonly noted on our referral sheet, but we also have trained them to look for, hey, is this kid being bullied? Is this kid the one who does the bullying? Is there violence in the home? Are they getting into a lot of fights at school? Is there fire setting? Are they, I always talk to the English teachers and the creative writing teachers. I say, take note of what your students are writing, because that's important, because if you look back, a lot of what these kiddos that committed these crimes in schools wrote some really, really disturbing things in like their journals or turning it into their English. Is it talking about death? Is it gloomy? Do you notice self-harm with the kiddo? There's just a slew of things that we look for, lots of different issues. Another thing, they may have all this, but are they involved in any extracurricular activities? Most of our TWITR students aren't involved in anything. They don't have any pro-social adults in their life. And that, when I say pro-social adults, I'm talking about good role models, people who follow the law, people who are good teachers and are encouraging. Most of our kiddos don't have that. The ones that do at least have one tend to do really well in the TWITR project. And next are assessments. So those are the reasons that a kiddo would be referred to us. And then when we go out and we do an assessment, first we go out and we do what's called a biopsychosocial assessment. We get a whole bunch of information from the parent, from the teacher, and from the school counselor and school as well. We ask about any past psychiatric issues, any past counseling. We even go into their medical history, because sometimes a medical issue can mask as a psychiatric issue, and really they just need that medical issue fixed and they don't need a psychiatrist. So we do dive into that. We dive into their development. Was it a normal pregnancy? Were they born early? Was there head traumas? Was there anything neurologically going on with that kiddo? We look at risk-taking behaviors. We look at self-harm with them. We ask a whole bunch of questions. And then we give a bunch of assessments to the student. We also give assessments to the parent telling us how they feel about their kid. And then we give the school teacher an assessment, and it's the ADHD assessment. It's called the Vanderbilt. The parent also takes the Vanderbilt as well. And with these assessments, we look at mania, which is the mania rating scale. We look at substance use, which is our CRAFT scale. We look at depression, which would be under our mood and feelings questionnaire. We screen for different types of anxieties. That's our SCARED. We look at PTSD. That's our National Stressful Event Survey. We look at hopelessness and loneliness. Those are big deals that we take into account with a student. And then our second year of TWITR, we added an assessment, and we all came on board the second year of TWITR, and it's called the Structured Assessment of Violence Risk in Youth, and that's our SAVERY. That assessment is actually done by us. So once we get back to the Health Science Center after getting all this information and we score our assessments and we've written our report, we score them. It's a subjective test. We score them from low to high on what their risk for future violence would be. We've had just a few that we rated high, and when we rate someone high, we notify the school resource officer. And this doesn't mean that anything necessarily changes for the student. It just means that there's other eyes watching out for that kid, and we're getting them the assistance that they need. It's not that they're in trouble and we're going to put them in jail or anything, but typically if a student rates high, it's because they have some type of assault charge already against them, or they've already been arrested, or they've broken some type of law that they've been arrested for. And that gives us another understanding of how severe this student is. So after we've done this, we haven't seen psychiatry yet. We really are just getting an idea of our kiddo. To really understand the kids, this is a way that I kind of explain it. It's a systems theory. This is the ecological systems theory of development. And so our TWITR children are really complex. And with our kiddos, the environment is influencing the TWITR student. And then our TWITR student is influencing their environment. So just some immediate things that are impacting them, and I want you to kind of look at is right here within this first circle. You've got the neighborhood, their neighborhood influencing them. When we go out to the rural schools, we're talking about mostly low SES. We're talking about crime and drugs, lots of poverty. Their peers, for a TWITR student, most of their peers that they associate with are delinquent, or they are delinquent as well. Their bullies are influencing them, or they are the bully. You've got peers that don't care. You've got social media influencing them. They're rejected. And then you've got sometimes some positive things too, schools influencing them. That could be positive or that could be negative depending upon how a teacher or the principals feel or think about that kid. If they're invested in their students, then that's a good protective factor for them. But sometimes teachers or principals or schools aren't as invested, and so that negatively impacts the TWITR student. Then you've got their home life, and most of our, I won't say most, a lot of our TWITR students in their home, you'll have domestic violence. These kids come from single parent homes, from transient families. I will say going out to our rural communities, there is a very, very small percentage of kids that we see that were actually born and raised in those rural communities. Most of the kids that we see will be what you would call outsiders. And what we've learned from our rural communities, if you're born and raised there, it's very community oriented. Everyone knows everybody. It's like a village helping out. But if you're an outsider, it's a bit different. And we have, most of them are transient families coming in, looking for work or looking for farming work or in the oil fields. There's some language barriers, especially we're located in Brownfield area. We have a lot of migrant workers that come through there. We've got incarcerated parents. A lot of these parents have been or are incarcerated. These kids have had really, really early disruptions in their childhood. Maybe the parent went off to prison. Maybe the parent was doing drugs and left, and these kiddos are being raised by a grandparent or somebody else. So there's lots of things we come in to take into account. It's very complex with these kids, and we don't just say a kid is one way by taking one thing. We take their whole development, what's going on in their environment, what's going on in their school, what's going on with their biology. And that's what we present when we go to psychiatry and we talk about these kids. Okay.
Telemedicine Services, this is what happens next. So what we do next after we've gone out and we've assessed the child, given them all the assessments, we decide if they need to see the psychiatrist. And so anyway, once we've determined that they need to be plugged into psychiatry services, we go to Texas Tech and we meet with the psychiatry department and we present the information that we've been given. And they will help us determine, yes, if the child needs to be seen. And at that point, we go back out and do the telepsychiatry appointments, as Amanda had mentioned. During that time, we will do all the steps necessary to inform the parent, inform the school. We'll set up the appointment, and we'll facilitate the appointments for up to 2 different appointments. In addition, the parents must sign the necessary legal forms, and that's a part of what we do as well. The parent does have to participate in the appointment. We do need the guardian there in order to continue. And lastly, following the telemedicine appointment, a determination will be made as to whether additional telemedicine appointment is necessary. We just follow up with as much and as best as we can.
And then also, after that appointment, we offer them referral sources, and I'm going to get to that in just a second. That's called the disposition type. So even after that first appointment with psychiatry, there's typically 4 dispositions that can occur with a student. They'll either get a medication recommendation and a follow-up telemedicine, or they'll get a medical recommendation with a follow-up telemedicine. Because remember, I told you sometimes medical issues can mask as psychiatric issues. And I think since I've been here, we've had one student that needed to have a medical follow-up because of their issues. Our psychiatrist was concerned that this could be medical rather than mental. So that occurred, and then we followed up with that kid after those appointments. There can be what's also a recommendation for non-medical therapies with no telemedicine follow-up. And what a non-medical therapy would typically look like is family therapy or individual counseling. Most of our students get recommendation for medication and a non-medical therapy with a telemedicine follow-up, and that's typically family therapy or individual counseling. Most of our kiddos need family therapy. As you know, we go in and we assess and we screen these kids, but when you really look at everything that's going on, it's a systems issue that's going on as well, and these families need some resources and need help. And then what we do out through the year is we develop resources for these kids, and we go around and we see what's available for them, and that's when we give them resources and referral options to counselors. However, that's one of the pitfalls, is sometimes it's difficult to get them the counseling that they need because of several things, because of traveling issues, because we have limited counselors that travel out to our rural communities. And sometimes our parents, if the kid's not doing well, it's usually because the parent's not doing well. And so the parent's needing some type of intervention as well. And unfortunately, TWITR kind of stops at that point right now. But these parents are needing some counseling and they're needing family therapy. And so that's why we recommend that. Let's see. I will say, after this, these are our typical dispositions. But over the last 3 years, some of our non-typical dispositions have included referred students who were removed from the school because they were arrested. I believe that I've been out to school a couple of times where there's been a child that's been arrested while we were there, or they were removed from the school by law enforcement. Others were removed because of pending assault charges, or there was physical or sexual violence in the home. And unfortunately, when we go and do our assessments, it doesn't happen all the time, but occasionally we have to notify CPS because we learn of some type of abuse going on in the home, or maybe the student is actually performing the abuse. And those are rare. That's not often. Okay, and our reporting and tracking. You want me to go ahead and do that one? Okay, so we do all this with TWITR, but what do we do with the information? Well, we do track these students. They come into TWITR, they may come in at the first 6 weeks, they may come in at the third 6 weeks of the school year. It doesn't matter when they come in. As soon as they come in, we begin to follow them, and we follow them every 6 weeks throughout the year. We get a baseline from them, their grades, their truancy, their discipline reports, and then we track to see, has Twitter made any success over the rest of the year while they're in school? We collect data on their demographics. We track these students with a de-identified number in a PHI system here at the Health Science Center. And we also re-administer our assessments to them at the end of their second telepsychiatry appointment, because we want to see, are they as lonely as they used to be? Are they as hopeless still? Is there still a lot of depression going on? Has anything changed? One thing that's really amazing about Twitter is that we've noticed as counselors, is we'll go in and we'll see the kid and we'll all be like, man, this is a rough one. This kid's sad, this kid's depressed, they've got a lot going on. We present them to psychiatry, but then on the day of the psychiatry appointment, they seem a lot better. And so what we've noticed is that sometimes they just need a pro-social human being, a pro-social adult, someone to come in and listen to them and let them tell their story. And sometimes after they just get to vent to you, they've already just unloaded a lot off their chest and they're already feeling better. And that's happened several times since I've been doing the Twitter project. Okay. All right, and then, so we're in our 4th year of Twitter now. And so now we know kind of some stuff that's going on now. So we do know that a lot of our kids are hopeless. Over 80% of them are. Over 50% of them have anxiety. Almost half of them have some type of separation anxiety and loneliness or school avoidance. And again, that loneliness and that school avoidance, what we've come to understand is really there is a lack of connection between them and the school system and them and their families and their parents. Through this, by implementing the Twitter process and tracking them, we have noticed that there's been a reduction in truancy, at least 17%. There's been a 25% reduction in discipline referrals for our Twitter students. And a 3.6 increase in the student's overall GPA. And that doesn't seem too big of a jump, but you've got to remember the kiddos that we're working with. I mean, the smallest degree of change is a big deal with them. And so as of this year, there's only been 2 students that have been referred back into our Twitter project. One of them, the mother was not compliant, and then the other one we were able to get additional services. One of the pitfalls that we have found with our Twitter project is the parents and the non-compliance. They tend to be sometimes more non-compliant than the students are. And so when they don't get follow-through appointments, typically it's because it's on the side of the parents. And so we do our best to maintain relationships with the parents and call them and remind them. We'll reschedule appointments 4, 5, 10 times with them if they need to. Sometimes parents think that it's not the best idea for their student at the time. And unfortunately, we cannot go into schools and see these kiddos without authorization from the parents. But we do say, hey, you know what? If something changes and you decide that you need some help, give us a call back. They're always welcome to call us back, and we'll get them back into the Twitter project. A kid can go through Twitter, graduate per se from Twitter, and then there may be something else that comes along the way later, and then they can sign back up for Twitter again, and we'll come back out to the school and see them. And that's really kind of the process of how Twitter is designed. Again, we're in our 4th year, and we are looking for extra funding now. We're looking at being a line item in the legislature. And I will say in December of 2016, the 85th Texas Legislature Senate for House Committee met to look at all of the mental health programs within like rural and urban areas, and Twitter was named best practice for our rural schools for program in mental health. And so we're really excited about that. Twitter really is one of its kind, state of the art. We're kind of the only ones that do this around here, and we've been presenting at numerous conferences. We're still presenting several this summer, and we're really excited about that. And so this is the idea of Twitter. This is the Twitter model. We're looking to expand even further and hoping to get extra funding for that. But I want to thank you. This is our Twitter project, and this is what we do. And I want to open it up for questions now. Hopefully we have questions, because I know when we present in conferences, this is an exciting topic, and we get a ton of questions. So I'm going to open it up now, and anyone who has a question, go for it.
Okay. That I did answer a question earlier because I did know the answer, but one question was, what is the percent of the population in West Texas versus the rest of Texas, and how many people are actually out there? So 12% of the population of Texas resides in the 108 westernmost counties that they refer to. So here's the next question. This care TWITR is offering via telemedicine. Is it team-based care where the medical provider and behavioral health provider are consulting together, sharing, working off a single treatment plan, and connected via a common EHR?
Okay. To explain what the EHR is to me. Do you know what that is, Becky? I'm not sure.
The electronic health record.
Okay, that's what I thought.
So actually, if I'm understanding correctly, you're serving as a presenter in this situation after the screening.
Actually, we do collaborate together.
Okay.
We work with the psychiatrist, and they do work with us, and we bounce ideas back off of each other. However, they are, because it's psychiatry based, they are the ones that make the diagnosis. They are the ones that make the main decisions. But we work with our psychiatrists. We work with the residents that fall under that. And oftentimes residents will look at us because we've been in the field longer than some of our psychiatry residents have. And they'll come into the psychiatry sessions, and sometimes we have to facilitate and help them understand the student and ask appropriate questions. So we do work with them. We do work off of a single treatment plan, and that is simply whatever the psychiatrist decides. We've done our report, we screen. Remember, this isn't a ongoing care. This isn't ongoing counseling per se. This is just to go in and screen and assess and link them up with services they need. I hope that answered that question. If not, maybe Shawn has something to add.
And you're not connected. You don't document in the electronic health record with Texas Tech physicians?
I do not. We do not do
Okay.
that. They have their own separate idea. Yeah, they do that separately. Yes.
Okay. Okay. So, are there any other questions?
Feel free to open it up. I mean, this is an interesting topic.
So I'm not seeing any more questions right now.
Okay.
Okay. So
right.
thank you. That is an interesting program.
Okay. Oh, we do have another one.
Oh, yeah, we do.
Okay.
Okay.
So it says, does TWITR offer intergenerational care if a child's issues surface problems with a parent or grandparent? Are those family members also included? Okay, unfortunately, we have to work with under the confines of what our grant says. And we offer referral sources. So we're going to notice that there's something going on, and typically it is within the family system or there's relationship issues. So what we do then is we try to offer those referral sources, say, hey, I think that you guys would benefit from some family therapy. Or the psychiatrist might even say, hey, mom, I think maybe you might benefit as well if you went and got your own therapy as well. But we don't necessarily provide the care for the parent to the grandparents.
Okay.
Okay.
So the next question is, what happens if a student needs long-term counseling? Can they access telemental health services?
Yeah, that is something that we lack here around the West Texas, and that is a broad thing that we're looking into. We don't offer the counseling per se with our TWITR students within the grant, because we have to do everything that's written in the grant. And again, the grant was designed specifically for telepsychiatry services and to intervene and to screen and assess. We do offer, again, those referral sources. As far as telemental health services, that's one of the things that we look into if there's counselors around here that provide that. But there's a pitfall to that, because the students got to be able to have availability to the internet in order to link into that therapist on their own, because that's not something that we provide. One thing that we do that's not part of TWITR right now is we are doing telemental health counseling here at the Health Science Center in what is called our Fit Lab, and we do that on a separate grant. But that is something that we know is needed, and hoping that we can get papers written and the word out of the need for mental health services and counseling in our rural West Texas areas or in our rural counties in general. And hopefully in the future, we can provide those services to kids and families.
Okay. Any other questions?
Okay, does this program include mobile health, giving the student ability to stay in touch and monitor conditions through a smartphone? Not at this time. We don't have that. We don't have mobile health with TWITR.
Okay. We'll give it a couple of minutes.
Okay.
See if we have any others pop up.
Yeah, there's so much that's needed around here. You can always find a need for things. It's coming up with all the funding that we need to offer the services.
Who funded your program and how long was it funded?
Right. Our program is funded by the governor's office, and it was initially funded for 2 years, and then we were able to get that funding extended for 1 more year, which is the 3rd year. Let's see. Yeah, 2 years. It was initially extended for 2 years. This is our last year that it's being funded. So we are working really hard with the government and the legislature office to get it on a line item because it's so beneficial right now. And I think we have a good chance of that because, as I just said, we've been named the best practice in our rural communities for mental health programs in schools. And then after that, we also have been working on another grant to help extend funding for TWITR so that we can expand. Because TWITR's been so successful around here, we'd like to take it further up into the panhandle or lower and really get it statewide eventually. That's kind of the big idea.
Okay. Okay. Well, thanks again.
Okay.
Just as a reminder, this presentation has been a part of the National Telehealth Resource Center's webinar series. The next webinar, could you advance the slide, Amanda?
Oh, yes, sir. Sorry. Let's see.
And I think we have that. Okay, next one. Okay, the next webinar for March, on March 16th, is about telehealth insurance considerations, and it will be brought to you by the Northwest Regional Telehealth Resource Center. So we will be sending out information to register for that one. We want to say that we really value your opinion, and we ask that you take a few minutes to complete the online survey. And I think that will, let's see. So this is what the survey looks like.
Oh, okay.
Okay. And again, this will be recorded and available via YouTube.